Usually, when you look at a diagram of human anatomy, there's this, I don't know, this comforting sense of precision.
Oh, sure. Like, it looks like engineered architecture.
Exactly. Like you look at a skeleton, you see a femur, and the textbook points right to it and says, there it is, leg bone.
Hmm.
It serves this very clear structural purpose.
Right. It's very neat and tidy.
Yeah. But the moment you step into the nervous system, that neat blueprint gets, well, completely scribbled over. We're looking at a landscape that is incredibly murky.
Murky is probably the best word for it, yeah.
Because right now, sitting in your skull are these 12 pairs of fleshy pables.
Yeah.
And they're literally the only thing stopping you from being trapped entirely inside your own mind.
Which is a terrifying but entirely accurate way to think about it.
Right. So today, we are doing a deep dive into these cables, the cranial nerves. We want to find out why the textbook definition of, 12 neat pairs is actually a historical illusion that's just full of imposters and rule breakers.
It really is the ultimate definition of anatomical muddy waters. I mean, these nerves are the absolute physical bridge between the abstract processes of your brain and, well, the physical world you interact with.
Which is everything we do, basically.
Exactly. We are talking about the wiring that controls everything from the mechanical movement of your eyes to the autonomous beating of your heart. But to truly understand them, you really have to look past those oversimplified wall charts in the doctor's office.
Right, which means looking at how we got those charts in the first place. Because before we can even begin to understand what these nerves actually do, we have to look at why medical science insists there are exactly 12 of them.
The history here is pretty wild.
It is wild. People have been trying to catalog the wires coming out of the human skull for over 2 millennia. It starts around 300 BCE in Alexandria with this Greek physician named Herophilus.
Yeah, Herophilus is a massively foundational figure here. He is often credited as the very first person to physically distinguish between motor nerves and sensory nerves.
So motor being the ones carrying commands out to muscles, and sensory bringing feeling back to the brain.
Right, exactly. And to figure that out in 300 BCE took a truly brilliant deductive mind. But his methods for proving this were highly, highly controversial.
It's putting it mildly, I think.
Yeah, he relied entirely on human dissection.
Yeah.
And historical accounts strongly suggest he actually performed vivisections on live criminals to trace those pathways.
Oh, wow. Yeah, so brutaler science for sure. But it set the stage. It didn't give us the final map, though, because centuries later, around the 2nd century CE, you get the Roman-Greek physician Galen.
Right. Galen.
And he formalized a system of 7 pairs of what he called encephalic nerves. And Galen's 7-pair system completely dominated European medicine for, over 1,000 years?
Over 1,000 years, yeah. But it was fundamentally flawed.
Why was it so flawed, though?
Well, Galen was operating under strict Roman laws that forbade the dissection of human bodies, so he had to extrapolate.
You had to guess, basically.
He dissected Barbary macaques, pigs, oxen, and he just assumed human anatomy was identical.
Oh, I see.
Yeah, and when you try to map the cranial nerves of a pig onto a human skull, you are going to miss critical differences. It's a profound testament to the power of established dogma that nobody seriously challenged his 7-pair pig anatomy until the Renaissance.
That is wild to think about. So it wasn't until 1543 that Andreas Vesalius published his landmark anatomical texts, and he finally corrected a lot of Galen's errors through his own, much more detailed human dissections.
Yeah, Vesalius actually looked at humans.
But even Vesalius didn't give us the number 12. The modern standard we use today wasn't actually established until 1778 by a German anatomist named Samuel Thomas von Summering.
That's right.
He proposed the 12-pair scheme, ordering them front to back, or rostral to caudal, based purely on where they exit the base of the brain. So let's unpack this.
Let's do it.
Neuroscience has advanced to an almost unrecognizable degree since the 1700s. I mean, we have functional MRIs. We can map individual neurons firing in real time. Why on earth is modern medicine still relying on an 18th century numbering system? It feels like we're running a modern supercomputer on 250-year-old legacy software.
What's fascinating here is that the numbering system persists specifically because it is geographically reliable, even if it isn't functionally hierarchical.
Wait, what do you mean by functionally hierarchical?
Well, there is a very common misconception that the cranial nerves are numbered by importance or complexity.
Oh, like nerve 1 is the most vital.
Exactly, and they aren't at all. Cranial nervi, which handles your sense of smell, is not somehow more important or more fundamental than cranial nerve 12, which controls the movement of your tongue.
Right.
It is purely an anatomical address system. Cranial nerve just happens to attach further forward on the physical mass of the brain. So, Summering's system survived because it provides a reliable physical map of the brainstem for a surgeon navigating the skull.
Okay, I get that. But if this geographic map is just a convention, when you actually apply modern anatomical scrutiny to this list of 12, the system starts to crack, right? I mean, some of these so-called cranial nerves aren't even peripheral nerves at all.
Right, let's look at the first two on the list. Cranial nerve array, the olfactory nerve for smell, and cranial nerve dissecans, the optic nerve for vision.
The big ones.
Yeah, but strictly speaking, neither of these are peripheral nerves. They are actually tracts of the central nervous system, the CNS, that just happen to stretch outward beyond the cranial cavity and into your face.
So they're like the brain's internal IT department working from a remote office. They're out in the field in your nose and your eyes, but they follow corporate headquarters rules.
That analogy is anatomically perfect, yeah. We know this because of their cellular makeup. True peripheral nerves are myelinated, meaning they have that protective, insulative coating made by a specific type of cell called a Schwann cell.
Okay, Schwann cells for peripheral.
Right. But the optic and olfactory nerves are myelinated by oligodendrocytes.
Oligodendrocytes, okay.
Those are specialized insulating cells that strictly exist only in the brain and spinal cord. And furthermore, these two nerves are wrapped in meninges, which are the tough, protective layers that enclose the brain itself.
Which explains a huge, often devastating medical reality. I mean, if you damage a true peripheral nerve, like a facial nerve in your cheek, it can often regenerate over time,
It
right?
can, yes.
But because the optic nerve is basically just brain tissue extended outward, it doesn't regenerate in the same way. That's why optic nerve damage from physical trauma or from diseases like multiple sclerosis is usually permanent.
Exactly. And if we connect this to the bigger picture, this dual citizenship of the optic nerve actually has massive clinical utility.
How so?
Well, because cranial nerve thestae has genuine CNS meninges covering it, it shares the exact same fluid space as your brain. So if a patient comes into the ER with suspected brain swelling raised intracranial pressure, doctors can literally place an ultrasound probe right over the patient's closed eye and measure the diameter of the optic nerve sheath.
Wait, really? Just over the eye?
It's just over the eye. If the brain is under pressure, that pressure travels straight down the sheath and it swells up visibly on the ultrasound monitor.
That is such an elegant diagnostic trick. Wow. So the front of Summering's list has imposters, but the back of the list does too. Because cranial nerve I-XII, the accessory nerve, is heavily contested by modern anatomists.
Very much so. The accessory nerve is primarily responsible for turning the head and shrugging the shoulders. The problem is that its motor fibers originate almost entirely from the upper cervical spinal cord.
Like down in your neck.
Down in your neck, roughly between vertebrae C1 and C5.
Wait, so it starts down in the spine, travels all the way up into the skull through the foramen magnum, that big hole at the base of the skull, just so it can turn around and exit alongside the true cranial nerves.
That is precisely what it does.
That is so inefficient.
It's very strange, which is why many argue it shouldn't be on the cranial nerve list at all. It is literally a spinal nerve wearing a cranial nerve security badge just because it takes a strange detour through the skull.
So if this geographic map is so flawed that it includes brain tissue posing as peripheral nerves and spinal nerves crashing the party, it makes you wonder what else they missed. And it turns out they missed a nerve entirely. The secret nerve. Nerve 0.
Ah, yes. The nervus terminalis.
I love that name.
It sounds like a movie villain, right? It was first described in fish, actually, and decades later discovered in humans. It's a microscopic nerve plexus located right near the olfactory bulb.
Wait, nerve 0. If it's a known human nerve that actually exists in the skull, why wouldn't they just update the system to include 13 nerves? Why keep it a secret or just call it 0?
Well, overturning 250 years of established medical textbooks is remarkably difficult. But also, the nervus terminalis is incredibly thin. It's so delicate that it is almost always accidentally torn away and destroyed during routine medical dissections.
Oh, so they just literally couldn't see it because they were destroying it.
Exactly, which is why it was missed for centuries. Functionally, it is believed to be involved in pheromone-like chemosensation, completely separate from our conscious sense of smell. Its very existence is just the ultimate reminder that 12 is a human convention, not a strict law of human biology.
Right. So now that we know who's actually in the club and who is sneaking around the edges.
Yeah.
How do we classify what these cables actually do?
To understand their function, we have to look back at a foundational framework established in the 19th century. In 1811, a Scottish surgeon named Charles Bell proposed that the anterior or front roots of nerves carry motor signals.
So the commands going out to your muscles.
Exactly. And he proposed that the posterior or back roots carry sensory signals, the information coming into the brain.
But proposing it is one thing. In 1822, a French physiologist named François Magendie ran the decisive animal experiments to prove Bell's theory was a physical reality.
Magendie's experiments were very methodical. He would surgically expose the spinal nerves in live puppies.
Which is tough to hear, but
Yeah.
yeah.
It is. But if he severed the anterior root, the animal would lose all ability to move that limb. But if he pinched the limb, the animal clearly still felt pain. The sensation was intact.
Okay.
And if he severed the posterior root, the limb could move perfectly fine, but it was entirely numb to any painful stimulus.
Which, naturally, sparked an incredibly bitter, nationalistic scientific dispute over who actually discovered it first, right?
Yeah.
British scientists credited Bell. French scientists credited Magendie.
The classic scientific priority fight happens all the time. But whoever gets the historical credit, the Bell-Magendie law gave us the basic vocabulary for all neuroanatomy. When it comes to cranial nerves, they operate on these first principles. They're either sensory, motor, or both.
Right, and medical students have used mnemonics to memorize this pattern for generations. I think the most famous one for the 12 nerves is, some say marry money, but my brother says big brains matter more. So the first letters correspond to sensory, motor, both, sensory, both, motor. But there's another layer to this wiring, isn't there? 4 of these nerves, 3, 7, 9, and 10, carry parasympathetic fibers.
Yeah, the parasympathetic nervous system is the rest and digest counterpart to your fight or flight response. These 4 cranial nerves don't just move muscles or relay touch, they control involuntary automatic functions.
Like what?
Well, they constrict your pupils to protect them from bright light, they make your salivary glands produce saliva when you smell food, they slow your heart rate down when you're resting.
Here's where it gets really interesting to me. If these nerves are so highly specialized, exiting from very specific, targeted nuclei in the brainstem, why are some of them such mixed bags of random functions? I mean, they aren't just doing one focused job.
It's a great observation because mixed nerves are actually the norm. Take cranial nerve 7th, the facial nerve. It is primarily motor. With a motor pin, it commands the muscles of facial expression so you can smile, frown, or raise your eyebrows.
Okay, that makes sense.
But it also carries taste sensation from the front 2/3 of your tongue, and it controls the glands that produce tears and saliva.
So it's handling tears, taste, and smiling, all bundled in one single cable.
Yeah, or look at cranial nerve I-XII, the glossopharyngeal nerve. It handles the mechanical gag reflex, it tastes things on the back third of your tongue, and critically, it continuously monitors your blood pressure through tiny baroreceptors located in your carotid artery.
Wow, so it's multitasking at the highest possible level. But if we're talking about multitasking, we have to talk about the ultimate outlier. We just mentioned the parasympathetic nerves, but one of them completely shatters the fundamental assumption that cranial nerves only serve the head and neck. I'm talking about cranial nerve X, the vagus nerve.
Oh, the vagus nerve.
Yeah.
The word vagus literally translates to wandering in Latin, and it lives up to the name.
It really does.
After exiting the skull, it drops down through the neck into the thorax and wanders all the way down into the abdomen. It innervates the heart, the lungs, the stomach, the esophagus, and a massive portion of the intestines.
So what does this all mean? We normally think of a nerve regulating the heart or the stomach as a boss barking orders, right? Like, beat faster, digest this food. But the architecture of the vagus nerve flips that entirely, because roughly 80 to 90% of the fibers inside the vagus nerve are efferent.
Right, afferent meaning they carry information from the body up into the brain.
It's mostly just listening. It's not a boss barking orders to the organs at all. It's a massive fiber optic feedback cable reporting the body's minute-by-minute status back to headquarters.
And that counterintuitive, afferent heavy wiring is the literal physical basis for what we call the gut-brain axis.
Yes, the gut-brain axis.
The brain isn't just sending blind commands to the gut. The gut is constantly updating the brain on its inflammatory state, its microbiome activity, and its digestion status. And those upward signals heavily influence our emotional and neurological baseline.
Hold on, I need to stop you there. I understand that the gut sends signals to the brain, But this isn't just a wellness buzzword anymore, is it? We are using medical technology to hack this feedback cable.
We absolutely are.
Like, the FDA approved surgically implanted vagus nerve stimulation devices for treating epilepsy back in 1997 and for treatment-resistant depression in 2005. How does electrically zapping a nerve in your neck actually treat clinical depression?
Yeah.
What is physically changing in the brain?
It all comes down to where those afferent fibers terminate. When you electrically stimulate the vagus nerve in the neck, those signals travel up into the brainstem, specifically to a relay station called the nucleus tractus solitarius.
Okay.
This tiny structure has direct projections to other areas of the brain, like the locus coeruleus, which are responsible for producing neurotransmitters, specifically serotonin and norepinephrine.
Oh, wow.
So by artificially stimulating that afferent data pipeline in the neck, you are literally forcing the brain to pump mood-regulating neurotransmitters into the cerebral cortex. You are using a peripheral nerve to alter central brain chemistry.
That is unbelievable. We've seen how perfectly these nerves regulate the body, from mood to pupil dilation.
Yeah.
But their physical pathways create a huge vulnerability.
Yes, they do.
To get from the brain to the face or the gut, these nerves have to exit the skull through precise, tiny, bony holes called foramina. It's incredibly cramped real estate. So when a nerve gets pinched by a blood vessel or infected by a virus, the results are dramatic.
Highly dramatic. And because the real estate is so cramped, cranial nerve pathologies are intensely distinctive. The most common one people might be familiar with is Bell's palsy, which affects cranial nerves VII, the facial nerve.
Named after Charles Bell, the same Scottish surgeon from the Bell-Magendie dispute, right?
The very same. Bell's palsy is a sudden, usually one-sided facial paralysis. It is often caused by a dormant viral infection that suddenly wakes up, causing the facial nerve to inflame and swell.
And because it's in that cramped space.
Right, because the nerve is trapped inside a rigid bony canal, the swelling chokes off the nerve's blood supply. The patient suddenly can't smile symmetrically or even close their eye on that side.
That's intense.
In fact, doctors look for a specific sign called Bell's phenomenon. When the patient tries to close their paralyzed eye, the eyelid doesn't move, but the eyeball itself visibly rolls upward and outward. It's actually a normal reflex we all have to protect the cornea, but it's usually hidden behind a closing eyelid.
That has to be terrifying for a patient to wake up and see in the mirror. But going back to our earlier point, unlike the optic nerve, the facial nerve is a true peripheral nerve. It's wrapped in Schwann cells, so it can regenerate.
Yes, thankfully. Most cases of Bell's palsy resolve substantially within 3 to 6 months once the initial inflammation subsides and the nerve repairs its own myelin.
But not all nerve compression stories have a quick fix. We have to talk about cranial nerve V, the trigeminal nerve. It's the largest cranial nerve, functioning as the main sensory nerve for the entire face. And it is the site of a condition so agonizing it was historically nicknamed the suicide disease.
Trigeminal neuralgia. It was first documented in the 18th century by a French physician named Nicolas André, who called it tic douloureux, or painful twitch.
The pain is described as sudden, electric shock-like sensations shooting across the face, triggered by almost nothing. Brushing your teeth, talking, even a light breeze blowing against your cheek.
And for centuries, doctors had absolutely no idea what caused it. It was considered idiopathic, arising spontaneously without any known anatomical cause. But in the 1960s and 70s, a neurosurgeon named Peter Janetta made a massive breakthrough.
What did he find?
He proved that trigeminal neuralgia wasn't some mysterious brain disease, it was a mechanical problem. An artery inside the skull was physically sagging and compressing the root of the trigeminal nerve.
Wait, so just the physical weight of the blood vessel was causing the pain?
It was the pulsation. With every single heartbeat, the artery would throb and physically rub against the nerve. Over time, that constant friction acts like sandpaper, wearing away the myelin insulation.
Oh, that sounds awful.
It is. When the insulation is gone, the electrical signals jump between fibers, a literal short circuit. So a light touch to the cheek gets cross-wired into the pain pathways, triggering an agony that feels like a lightning strike.
And Janetta pioneered microvascular decompression surgery to fix it, right?
Okay.
A surgeon literally goes into the skull, physically lifts the throbbing blood vessel off the raw nerve, and places a tiny Teflon sponge between them to act as a shock absorber.
Exactly.
It stops the short circuit immediately. It's pure mechanical genius. But sometimes it's not a blood vessel causing the short circuit. Sometimes it's a virus deciding to wake up and cause chaos. like in Ramsay-Hunt syndrome.
Ramsay-Hunt syndrome is a brilliant demonstration of this tight anatomy. It was described in the early 1900s by an American neurologist, James Ramsay-Hunt. It occurs when the varicella-zoster virus, the exact same virus that causes chickenpox, reactivates.
Wait, reactivates?
Yeah, after you have chickenpox as a child, the virus never leaves your body. It retreats and hides out, completely dormant inside your nerve bundles. In this case, it hides in the geniculate ganglion.
Which is basically a tiny swollen junction box for the facial nerve.
Exactly. When the virus reactivates decades later, it causes facial paralysis, much like Bell's palsy, but it also produces a highly painful, blistering rash deep in the ear canal. But here is the critical part that shows how cramped the skull is.
Right.
Because cranial nerve 8, the vestibulocochlear nerve, which handles your hearing and sense of balance, sits immediately adjacent to the facial nerve in that tight bony corridor. It frequently gets dragged into the pathology.
The collateral damage. So the patient doesn't just get a paralyzed face, they suddenly experience severe vertigo, ringing in the ears, and hearing loss. It's like a fire breaks out in one apartment unit, the facial nerve, but because they share a paper-thin wall, the totally separate apartment next door, the hearing and balance nerve, gets severe smoke damage.
That's a great way to look at it. And this raises an important question. Why is understanding these highly specific, clustered symptoms so important for modern medicine?
Right. Why do doctors need to know this exact layout?
Because they serve as the ultimate non-invasive diagnostic tool. If a patient presents with isolated facial paralysis, the problem is likely further down the facial nerve's pathway. But if they have facial paralysis, A&D, severe vertigo, A&D, hearing loss all at once, the doctor knows exactly where the inflammation is happening, right at the specific anatomical bottleneck where nerves 7th and 8th travel together.
Wow.
It allows doctors to pinpoint the exact millimeter of a problem deep inside the skull based purely on physical symptoms.
Which brings us to the everyday relevance for you listening right now. You don't need a rare syndrome like Ramsay-Hunt to interact with your cranial nerves. They dictate medical protocols and daily life constantly. First off, let's debunk a massive pop psychology myth. You've heard the claim that humans only use 10% of their brain.
Oh, yeah. It is entirely false. Sometimes basic sensory or cranial nerve reflexes are misrepresented by pop psychologists as unlocking some hidden brain capacity. In reality, you use all of your brain, and your cranial nerves are constantly feeding it data.
What a cranial nerve exam actually reveals is intensely practical. Think about the standard FAST or BE-FAST stroke assessments that paramedics use worldwide.
Very true.
When a paramedic asks a patient to smile to check for facial droop, or asks them to repeat a sentence to check for slurred speech, they aren't just looking for generalized brain damage. They are conducting a rapid, highly specific cranial nerve exam on nerves 7, X, and 12 right there in the living room or the ambulance.
Or consider the early days of the COVID-19 pandemic. When millions of people suddenly lost their sense of smell and taste, that wasn't a respiratory symptom like a stuffy nose.
Right, it was neurological.
Exactly, it was a direct neurological hit. The virus was actively attacking the supporting cells of the olfactory nerve, cranial nerve where he's high up in the nasal cavity.
Or even just going to the dentist. If you've ever had a lower wisdom tooth pulled, the dentist has to navigate around the inferior alveolar nerve, which is a major branch of the trigeminal nerve, cranial nerve V.
Yeah, that's a tricky one.
If they accidentally nick or stretch it during the extraction, you can end up with lasting or even permanent numbness in your lip or chin. You're constantly witnessing the stakes of cranial nerve anatomy in real time.
The ultimate takeaway here is that a cranial nerve exam is a perfect living map of the brainstem. Because each nerve's function and physical exit point are so precisely mapped, observing a patient's eye movement, testing their gag reflex, or checking their pupil dilation allows a doctor to localize a brain injury flawlessly.
That's incredible.
They can often determine exactly where a stroke or a tumor is located in the brainstem without needing a single high-tech MRI scan.
We've covered a massive amount of ground today. We started with a 250-year-old numbering convention that forced us to view the nervous system as a neat list of 12. We looked at how early anatomists like Herophilus used brutal vivisections to chart these pathways, and how Galen's reliance on pig anatomy misled medicine for 1,000 years.
We really did span millennia.
Yeah, and we uncovered the imposter nerves that are literally just brain tissue stretching into our face, and explored the incredible reality of the wandering vagus nerve, acting as a massive data highway that lets our gut dictate our mood.
It is a profound reminder that human anatomy isn't always clean, binary, or perfectly engineered. It is messy, it is full of evolutionary workarounds, but those complexities serve incredibly sophisticated purposes.
So as we wrap up this deep dive, we want to leave you with one final thought to mull over. We talked about how the optic and olfactory nerves are quite literally tracts of central brain tissue stretching out into our eyes and nose. And we discussed how the vagus nerve is a massive fiber optic cable sending the gut status up to fundamentally alter our brain chemistry and emotions.
Right.
So if your eyes are just an extension of your brain and your stomach is constantly programming your mood,
Hmm.
where does the body actually end and where does the brain truly begin?
That muddy water just keeps getting deeper.
It really does. Thank you for joining us on this deep dive. Keep questioning the amazing machinery inside your own head, and we'll catch you next time.